I'm a clinical researcher with an interest in sort of disorders that overlap risks of clotting and bleeding, and particularly hematologic malignancy patients who have thrombosis and have to be treated with anticoagulants and are therefore at increased risk of bleeding. The particular issue that we were addressing in our updated guidance document was the management, again, of these cancer-associated thrombosis patients who have thrombocytopenia while they're requiring anticoagulation. And we updated the guidance document from the 2013 version. Primarily, we changed our recommendations for the management of acute VTE, meaning within 30 days of the index event, and thrombocytopenia, opening that up to allow the clinician to distinguish between a patient at high risk of recurrent thrombosis or low risk of recurrent thrombosis, and subsequently introducing the option of a dose-modified strategy for anticoagulation in patients at lower risk for thrombosis, while maintaining our recommendation for therapeutic treatment of patients at high risk for recurrence. I would say, the major challenge is that there's simply a lack of data. There's no high quality data. And so there are in general two different management strategies, one being therapeutic anticoagulation with platelet support, and another being dose modified, meaning reduced dose anticoagulation, then holding off on platelet support. So those are sort of the two active strategies right now. One question that's arisen with recent data suggesting that direct oral anticoagulants are beneficial for cancer-associated thrombosis has been whether or not that would be relevant. At this point, as a subcommittee, our guidance document recommends against that, specifically in the thrombocytopenic patients, because again, if there is a downside of DOACs in CAT, it is that it's at increased risk of bleeding, and we want to minimize that in this population.